Okay, our next presenter is Dr. H. Steve Byrd. Dr. Byrd has been practicing as a plastic surgeon in Dallas, Texas since completing his residency in 1978. He is board certified by both the American Board of Surgery and the American Board of Plastic Surgery. He entered private practice at Baylor University Medical Center at Dallas and was appointed vice chairman to the Division of Plastic Surgery at the University of Texas Southwestern Medical Center following his residency. Since those appointments, he has been distinguished as a full professor at the above-mentioned university and has been elected Chief of Service at Baylor University Medical Center at Dallas. In addition, Dr. Byrd serves as Director of Plastic Surgery at Children's Medical Center, is an officer of the Dallas Society of Plastic Surgeons, is an officer of the Rhinoplasty Society, and a member of the board of the Plastic Surgery Educational Foundation. In a recent poll, Best Doctors in America, Dr. Byrd was elected by his peers as one of the top plastic surgeons in the United States. He accredits this acknowledgement to his uncompromising commitment to the highest standard of patient care, to the development of innovative and state-of-the-art surgical techniques, and to the betterment of his specialty through the educational and governmental process. We are very fortunate to have you here with us today, Dr. Byrd, and I'm going to go and let you be the presenter so that you can start sharing your screen. Let me see if I'm able to do this. For some reason, I am unable to drag the ball down. Michael, if you're able to help me, I would appreciate it. Otherwise, I will. I appreciate your patience, Dr.
No
Byrd.
problem.
Here we go. Okay, I'm able to see you now. It's not letting me. 1 second. Okay, Dr. Byrd, you should be able to share now. Thank you.
Okay. Let me just enlarge the screen. Okay, that should be, you should be able to see my full screen now. Is that correct?
Yes, we do.
Okay, well, thank you for inviting me to participate in your symposium. And I'm honored to be here to share one of my recent passions. Hopefully what we'll cover is all the stuff that has evolved over the past 10 years that pertains to caring for newborn infants with ear malformation and deformity. So it's exciting stuff, and I think highly applicable to your parents and to their babies. First, I'd like to talk to you a little bit about the embryology of the ear. Back in the very early phases of conception, the newborn infant will appear more as a fish with gills than as a humanoid form. But of significance is the fact that the cleft that exists in the gills, if you look at that figure A, there's portions of, from the upper arch, contribution to the outer rim of the ear, which is purple, and contributions from the lower arch, number 2, which is sort of a yellowish color. And you can see that these two embryologic components unify to form the sort of the helix around the ear and then the intercartilaginous matrix. And so what we see in these ear deformities and malformations is points of imperfection between these zones of union. And also, we see that the vestigial muscles of the ear can get malpositioned. Now, these muscles have no function in the human. In lower animals, they cause the ear to flicker or to move so that if there's a insect biting the ear, that can knock it off and that kind of thing, and it can redirect the focus of the ear for hearing. But in the human, they're nothing. They're not doing anything, except sometimes they get malpositioned in part of that embryological matrix. In normal position, the little bands of these muscles account for the shaping that occurs in the cartilage. But when they get malpositioned, they contribute and cause the malshaping. Here's a picture of a stall's ear that was operated on. This actually is from Dr. Yatsunagi from Japan, who was big on identifying all these muscles. And you can see he's lysing or cutting away that muscle that's contributing to this band and to this abnormal cruise. So we recognize that there's a lot of interesting things going on in the formation of the ear that accounts for an abnormal shape. This is a newborn baby with, as I could see, almost perfect ears. There's a nice, smooth circumference of a helix around the ear. There's this nice cartilage bend. This is called the antehelix, and then it continues on up in this direction called the superior crus. And this is an inferior crus. And in between is sort of this triangular fossa with the shadow. And then down here, the concha bowl, which is, of course, where we can fit our earbuds and such as that goes to the canal. And then the earlobe is here. So these are all components that have a standardized shape, and it all relates to physiology and what's happening to those muscles and the distribution as the ear is formed. So back in the late 80s, random reports had been that you could take tape and glue and such as that and apply it to the ear and change the shape. For me, my first encounter with this was when I was as mentioned, the director of the cleft and craniofacial program at Children's, but I was making rounds in the city, and one of the neonatologists asked me to see her grandson, so I presumed it was for a cleft lip, because I was always there doing molding of the alveolar segments and the nose and the lip to get it all lined up so that at 3 months of age I could operate and everything would come together in a more perfect balance. But no, it was a deformed ear. And I told her, I said, I'm not sure this will really work. There's some reported evidence, but that's a different kind of cartilage than what we're molding in the nose and in the surrounding lip area. But anyway, she asked me to try. So I went to the hardware store and got some different super glues at the time and some solder and tubing and made stents. This is actually a stent I made out of dental compound, thermoplastic dental compound. And it worked. She, the baby changed. Now, what I learned over time when we were doing this, and I probably did close to 400 babies using these one-off techniques, so many that came to me that I had to hire personnel in my children's clinic because I mainly was doing surgery just to keep up with making these little stents. And so what we got was not really a perfect ear like I showed you on the right here for reference, because what we were really doing is taking a crumpled mouse-shaped ear, as is on the left, and making the rim perhaps a little more curved, but we weren't correcting the full bend in the cartilage. We weren't correcting the collapse that was down here in the concha where this was piling over. There was just a lot of, maybe we'd say improvement, but we were falling way short of this beautiful ear I'm showing you on the right. We just weren't getting there. Somehow or another, I can't make my thing advance. And that led me to see how come we are seeing so many of these babies in this clinic. I had been aware that this was a common problem. So we went to the Baylor nursery and we looked at 100 consecutive births and were stunned to find that 33 of the babies had misshapen ears at the time of birth. At 1 week, 11 of the deformities had self-corrected, but 22 infants had persisting deformities. And when I looked at this as a surgeon and say, okay, what about these deformities that are not correcting? 10 of those, half of those with persisting deformities were the kind of deformities where I would have had to do cartilage grafts or skin grafts to relieve the disfigurement. So what did this lead to? Well, we had done all these one-offs and corrections using the stents and glues and things, and I was dissatisfied with the outcomes. At the time I went back to the nurse, actually took casts of the ears made out of soft silicone and made paper models. And what I learned was we needed a posterior force behind the ear to get that cartilage shaping right. And this you see on this paper model is where it needs to be. And then there needs to be a nice around the edge. And so with this cast, we embedded this rise or this elevation, and then we captured the outer curvature. And so what we were in the midst of here was creating a base foundation for shape. And what we then did was we looked at babies that at birth that ranged roughly from 6 pounds to 12 pounds. And then from the moulages of their ears, we noted that the projection did not change much. The normal projection for these ears was 5.5 millimeters, and it gained maybe out to 6 weeks. And we captured the inner shape of the helix here, and there's the 5 millimeters where that area is. Then we increased the size of the helix dimension, slightly larger, but hardly, half a millimeter at the most. And then these elevations behind the ear, we went at 2 millimeters and then increased them to 4 millimeters in order to accommodate the growth and shaping that we felt would be necessary. So this data led us to creating this system. And this is that base plate. There's the outer curvature. There's that inner space and little elevation behind the ear. And so when that's oriented right, it automatically causes the rotation of this perimeter to fall into alignment. And then we have these molding additions that fiddle on the perimeter to hold the exact shape, not just a one-off shape, but a shape that matches a newborn ear for that same size and weight. So there are different sizes of these. And this little plug goes in the center of the ear and pushes down and expands the concha. So we're really now addressing with this technology the entire of the ear as far as cartilages are concerned. Uh-oh, I went ahead of myself here, sorry. Here we go. Apologize for that. So what I'm showing you here is that device that I just reviewed being used. We shave an area around the ear. An adhesive holds that base plate, and there's that little guiding bar behind that's making this cartilage go this way. And then because we have this outer perimeter that's now in alignment with what we know a normal newborn would have, we can hook these shaping devices onto the perimeter and with that end ratchet, put the center piece in to expand this area and then put the lid on. And so that's how that device is working. Now, After using this device and combining the data with the previous studies where we were doing molding, we had to address the issue of, well, are we over treating? Do the ears self-correct? And we don't really need to be doing this. There was a publication done by nurses in the Canadian Pediatric Society back in 2005, and they took babies with deformity, 200 of them, arbitrarily divided them into half that were treated with molds and the half that were just left untreated. And what they saw that among the untreated, the deformity remained or progressed 70%. In the treated group, they correction. So this is the only study I could find where there was a randomization actually denying treatment to the babies when they had deformity. But it does, the idea that the ears are just going to get better, the majority of the time they don't. And some other studies that showed pretty much the same. This one they showed no self-correction, but it was a much smaller group, 20 patients. And where this is applicable today is that what we're seeing is that two things. One, the issue that, oh, they'll just go away and get better is a bad teaching. The majority are not. The other is that in pediatrics, there's a valid concept of watchful waiting. That means that when you find a baby with a hole in the heart or a hernia, there's nothing wrong with waiting because a lot of those go ahead and close. So the bottom line is that was easily applied to these ear deformities. And yet what we know is that's not the case. They end up persisting, in the majority of cases are getting worse. And the other thing is they looked at it just as a cosmetic issue. This had no valid other than just making the ear pretty. I'm having trouble advancing here. I apologize. And back to the issue of being just a cosmetic thing. Fortunately, the AMA addressed this in their bill H47 475 992. And they defined that reconstructive surgery or treatment is performed on the abnormal structures of the body caused by congenital defects, developmental abnormalities, and they added trauma, infection, tumors, or disease. It is generally performed to improve function, yes, but may also be done to approximate a normal appearance. And so the AMA encourages that when we're taking a baby with facial cranial malformations, ear deformity, that those can be corrected in children and avoid the bullying and the teasing and the psychosocial trauma that can follow. So we don't consider it cosmetic at all. We have a basis with our AMA to say that this is something that is important in terms of correcting appearances. We then did our own review of the data, and we found something startling. I want to really emphasize the outcome. We had 840 ears that we looked at, and we piled them into 3 stacks. Babies that were treated and had beautiful normal correction, babies that were treated and they ended up still potentially needing surgery, and then another stack where the ears were somewhere in between. And what we learned was that when we opened the group, the patient charts that had the perfect outcomes, the prevailing fact was that they had been started not within 7 days, but within 14 days of birth. I don't know how I got 7 days on there. And when we did that, we had 94% good to excellent outcomes. When we opened the group that had that would still need surgery or had a poor outcome, let me put it that way, they had been started after 3 weeks of birth. So what we learned was that early diagnosis and treatment was imperative to what we were doing. Now, there were exceptions. There were a few babies that did, and that started in the first 14 days that had poor outcome. And there were babies that were started after 3 weeks that had good outcome. What happened in the first, the prevailing factor in the first group that were started within the appropriate time was that they would get an allergy to our tape or some allergic reaction to the device, and then we'd have to stop. We've largely corrected that problem, but that nevertheless prevailed in the data. So I think we're looking now at much higher correction rates, at least 96%, 97 perhaps. And then in those started after 3 weeks, how did we get a good result? Well, we did find that the outer perimeter was more fragile and thereby more susceptible to late starts in molding than when it was involving the inner core of the thick cartilage of the ear. So one study came out of Presbyterian Hospital in New York City where they actually put these devices on while the baby was in the nursery, so starting it within 2 days. And they only did a single application for 2 weeks with complete correction. So that led to the fact that started the shorter duration of treatment and the better the outcome. Now, I will say that I'm not personally comfortable with doing a single application because after 2 weeks, there's still a lot of maternal estrogen and hyaluronic acid in the ear cartilage, and it's still very moldable. I think it sets us up for relapse. And when I reviewed the long-term data of this particular study, I did see some babies in there that were becoming prominent. So I feel like that if you start early, you still want to complete a full course, which to me is a minimum of 2 applications and often 3 applications before you stop. Each application lasts 2 weeks. So what do we do with these? What do they look like? How do we classify them? What are we really dealing with? Basically, they come in 2 groups: deformities, where there's no missing tissues, just misshapenness; malformations, where there are varying degrees of missing skin and cartilage. Now, we'll say that a lot of times the malformations in our literature are shown not to be susceptible to molding and therefore are more directed toward surgery. We have found that not to be the case. Now, these 2 entities, even though they sound extremely different, and in fact are, they may appear very similar. And as I said, we now find molding appropriate for both. It is true that it's harder to do the malformations because in that case, you sometimes are having to stretch both the skin and cartilage. Here's a malformation on the left. You can readily see there's missing skin and cartilage in the ear, and a deformity on the right where it looks a bit extreme, but where there's actually no missing tissue. The other thing that is where the 2 various deformity versus malformation presents itself in a conflicting way is the prominent ear. Both of these ears stick out too far. The one on the left has no missing tissue and is just rotated out too far. The one on the right is way out along the perimeter and in different parts of the ear here, right? Dents and contractures, that's from missing tissue. So it's almost like the outer perimeter is a purse string around the ear, crunching it and pulling it forward. And that's a malformation. Again, treatable, but much more difficult than the one on the left. So get to just the prominent ear, which is hugely common. But in this baby looking from behind, you can see that the right ear sticks out further than the left. But I would submit to you that when plastic surgeons, pediatricians, anyone who looks at these babies, even if both ears were like the one on the right, all you would conclude is that this is a cute baby. They do not look like they need anything. And yet, what we know and how we resolved this was we studies on what we created this projectometer, and it's a ballpoint pen that's color coded. And if you put this pen behind the ear in the upper third in this zone, and the ear's in the green, that's projecting 5 to 7 millimeters, that's totally normal. On the other hand, if it jumps out into the red, that's 10. That baby at age 5 will be 3 times that and look like the patient on, which is a 5-year-old. So what's happening is we can now use this projectometer, and it's easy to diagnose. Now, again, I'm going to emphasize it needs to be placed along the upper third, not down here behind the earlobe, because the mastoid process of the skull has not developed, and you'll get false positives. But used up here, it's highly valuable. And those babies, when they grow up, are going to have their ear almost at a right angle to their face. This is one that I treated, and it's projecting at, 30 on the left and 28 on the right. So you can see that they really get sticking out there, and he would have projected in the red on the study. Now, the other deformity is lidding, where the upper part is just folded over. It, again, can masquerade as a deformity on the left or as a malformation on the right. Looking closely, you can see the indent where that arrow is pointing, and there's missing skin or cartilage on the underside of that. When you take a Q-tip or cotton applicator and lift or probe up the rim, this one will come up, the deformity will just lift up easily. The one on the right will want to flip back down, and there'll be resistance trying to lift that, indicating the missing tissue. And so this lidding phenomenon can end up with folded over breaks in the cartilage, as shown in the middle. It can end up folding over almost all the way down half the ear, and that's of course called Loppier when that's the case. But it's easy to diagnose, and this is not one that's prone to self-correct at all. Neither is prominent. This one is Spock, or this is the Martian ear. Left alone, this abnormal bend, rather than going up, takes this turn out to the side and creates an elf ear, a Spock ear, a Martian ear, all these things as it grows. Interestingly, this one does have a tendency to get back in some instances. Affected the rim, though, how thin it is, and that's one of the manifestations. And if this doesn't fully correct, the ear flattens across here, and it turns into what's called a clamshell ear, where there's no helical rim and just a real wide, flat surface. So all of these have manifestations, but the Stahl's ear is one that you see a lot of. We watch it pretty closely because if it's self-correcting, we'll watch. You usually see self-correction beginning within the first week of birth. So the next thing that when we're looking at helical rim deformities is just something that's involving that a portion of the embryology that pertains to the outer perimeter, and you can see that it can be collapsed, can be just bent in weird shapes. The thing we have to watch for is in the box that's highlighted on the right, you'll see that rim is compressed in like the others, but there are little areas of and that indicates there's an underlying malformation. So it, once again, can masquerade as a deformity or as a malformation. The malformations have rigid fixation. You can't lift it away, and you can feel those little indents as deficiencies. This is a weird deformity that's just a big bar going across the center of the ear called a Conchal Cruise. When it's present, it will cause the central part of the ear to overdevelop and will cause the ear to become prominent. It may not be prominent when you measure it, but this is one that grows into prominence. If this bar is located lower, this one is not that way, but if it were to be coming off right here, it would push the external auditory canal closed, causing a problem with toilet, examination of the canal, and frequently resulting in the necessity of a canalplasty, where that cartilage is being removed to open the canal. And then the other groups are just mixtures. Here's a Conchal Cruise with lidding. Here's a Conchal Cruise with absence of bend in the ear here, and sort of a degree of prominence. And this one has lidding, stalls, Conchal Cruise. It just is a mixture of all of that. So what I was going to do is show you some results that we're getting with molding. This is a baby that doesn't have this bend in the cartilage here, and there's a beginning bend here, and has this bad Conchal Cruise going across. You can see that by putting that mold behind the ear oriented right, we have this, and the outer perimeter is now shaped evenly, and this hollow in here is opened up and expanded as it should be. This is one of the liddings, again, a mild Conchal Cruise. Notice how we've taken the perimeter of the ear, gotten this point out of it, and made it a smooth, normal shaped ear. This is the stalls coming up here. Notice that the rim is nearly absent in this part. This one's folded over. Again, we've taken the outer perimeter, put it into a perfect symmetry, and we've taken this part and lifted it so that now we have the normal relationship between the inner bend and the concha. So a lot of change going on in the central matrix as well as on the periphery. Another one with a bad Conchal Cruise, absent bar here. You can see how that has shaped out. Another one with, this is a lidding malformation. You see the indent right here. And you can see the band of constricture there where there's a fusion. But in spite of that, we were able to force shape into the ear so that it is now holding what would be a normal missing tissue. So again, that do they improve with age? Well, my task as a surgeon was fixing all these different things that were ignored in infancy. Here's one right here that's at right angles to the face in terms of prominence. So taking it the next step, looking specifically at malformations, we looked at 484 ears, and 127 of them had malformation. And we treated them using our technique that we've just gone over. And we then divided the constricted ear into different classes of increasing severity. All of them had some small, they were shorter, smaller ears, vertical height was less. They all had some flattening of the superior cartilage in here. They had hooding, and sometimes they had prominence, but most of the time that was mild because everything was constricted and tight. This is a class 1, similar to the one I just showed you earlier, and you can see there's a fusion point right here, but we have essentially a normal ear that would require no further intervention. This is another one, a little bit more severe. See the indent here, the collapse all the way around. There's missing. And you can see that after treatment here, we still have a little residual where we don't have where we weren't able to totally pull that away and totally pull that away. So these are harder to treat, but the treatment, I think, will stop us from doing surgery on the majority of these kids. So looking at the class 2s, they have more tissue missing. This is an example of class 2s. And this is an example of class 3s where there's even more missing tissue. Right next to that would be where the majority of the ear is gone and all you have is an earlobe. So in reviewing, when we look at the class 1s, we pretty much take them to normal. With constriction. And then in looking at class 2s, they go close. This is what I'm saying is they're going to a class 2 is going to a class 1, although there would be nothing I would do to that ear as a surgeon. Similarly on this ear, there's nothing I would do. Having trouble getting this to advance here. Here we go. Another one, pretty dang good shape. When I look at these, all of them are such that I'm totally happy, and I'm not advocating that they would need further reconstruction, even though they have not attained full normal height. Now these are really severe. You can see on this one there could be some work done surgically to lift this a little bit, maybe even remove part of it. This one is a small ear, but beautifully shaped. I wouldn't do anything. He was doing rib grafts and skin grafts, and that in itself has a lot of unattractive features. This one would benefit some touch up from surgery. This one also would, but very improved, so that mainly all you're having to do is work on the rim, a little bit out here on the periphery. So where we are with this, and why I'm so delighted to be sharing with you guys, is that we have a new standard of care for these babies' ears, and that revolves around early diagnosis and treatment. And when it's done in the office, there's no pain, there's no anesthesia. We see the baby over a period of usually we're seeing them every 2 weeks. On the malformations, we see them every week. They have a lump sum fee that covers everything over that 3 months. Insurance is done the same way. Insurance is the major payers. We've had coverage. Medicaid, we've had mixed. We do not file Medicaid in the office because we cannot get an approval from them that says they will cover it and not come back after us if we fail to, if they decide against it. So it just puts us at too much risk. There are some pediatric practices that refer parent wants to do that. So the management rationale then is to diagnose early at the newborn exam, alert the parents, suggest getting baby pictures as soon as they can out of the hospital, so that if they are candidates for the device, they won't have that messing up their pictures. But a follow-up exam 5 to 7 days out to see if it's self-correcting, because if it is, we just celebrate it. If it's not, then we start thinking, hey, these are going to need to be molded. If they're a little better and we're not sure, we check them. And then if it's not correcting, then we go ahead and mold, because remember, 4 days. And how do we help you guys with this? Well, we have a number that we'll give you that you can call, and the parents can send, or you can send a picture. We look at it, we'll contact the parents, and we'll get back with them for a follow-up check at a week and see what the picture looks like. And if there's a reason for molding, we can clear their insurance issues and get them in plenty of time. So as I mentioned before, I think we need to hold on to this normal treatment interval, 4 to 6 weeks. I think stopping soon may giving way to relapse. Even if we attain shape, and we often do get really great shape within one application, we don't stop. Sometimes breastfeeding is thought to increase the maternal estrogen levels and thereby make the ear soft for a longer period of time. I don't know that I've seen that 100%, but I do think that our minimal cover all that is 4 weeks, and then we can use retainer tapes to hold the position if we need to. What about premature infants? Well, the reason this is up here is because there is the maternal estrogen and related hyaluronic acid in the ear starts disappearing in 2 weeks and it's gone by 6 weeks. And this relates to the hardening of the ear and the resistance to successful treatment. I've had a number of preemies parents come in and they were beyond the 2-week interval from their birth. And hey, there's just too much chance we're going to get a failure. I hate to bill your insurance and you for this, and then it not work. I've had enough parents say, would you just try it? And out of 8 consecutive babies, it was 100% successful. So now we realize that maternal estrogen and hyaluronic related to that are not the sole answer. So what we do is we'll give your baby his normal gestational age, add 3 weeks to that, and whatever that date is still within our treatment interval for a good outcome on a preemie. And we've now done, since this slide was made, 4 more. I had one that went beyond this 3 week plus gestational age interval and had a failure. The baby was about 2 months past that time, and it didn't work. So there is a limit. We're still refining what we know about the preemies. Complications, if they get milk inside the device, they'll get a yeast infection very often, spillage inside the device. We bring them back, clean it, and reapply or take the parts off. When we have these high conchal ridges, sometimes we put too much pressure and we'll get an abrasion like this. This will give off a bad odor. That's what the moms complain about. And we'll take that device out, put some bacitracin on it for 3 days, and then go to the farmer. So those are the kind of things that we see as complications. They're sort of minor abrasions. This is one on a malformation where we were pushing hard right here, and that'll heal within 2 or 3 days, and then we go back to treatment. So my conclusions: early diagnosis, early diagnosis, early diagnosis. That's the bottom line. And as I mentioned before, 14 days, there was an error in that slide earlier, not 7 days. Effective for both deformation and malformation. And we do training. And I have this video. I know it's been hard to get things to play, but maybe it will, that shows an application. Superior limb of the triangle. Continuation of the antihelical fold.
I think it stopped, Dr. Byrd.
Yes, it was, but the volume was a little low, and then the video did stop. It looks like on my screen, it looks like you're not sharing your screen any longer. Okay, it's coming back up now.
I think he's muted.
Yes, Dr.
Can
Byrd.
you ask him to unmute? There he is.
And that can be shown how that's really putting this an applicator behind the ear and following it back. That creates the superior limb of the triangle. Can you hear me now? Now we do need to correct this to follow this. How am I doing on time is what I was trying to figure out. I don't want to run you over.
I think we'll be fine. You're unmuted right now.
Okay. Well, what I was going to do is talk over this since it's so quiet. I'm showing you the application of the deformity.
There's a lot of feedback right now with you talking, so I think either mute video.
All right. Conchal Cruise is a very common deformity that's an associated.
Dr. Byrd, I think you need mute for us to hear the video audio. We aren't hearing any audio.
This is Amy. I work with Dr. Byrd until he can get his. He has just shaved the baby's ear and he is just cleaning that up. And this sometimes poses to be a little traumatic for the parents. They don't like the hair to be shaved. So there are different, depending on the size of the baby's ear, Dr. Byrd's have various sizes of the ear well, the application to place. And here he is just going to tuck the little ear into the ear molding system. And this little video only has right at about another minute left. Okay, he has muted it so the video doesn't, play back. And so you can see that the tape there, Dr. Byrd uses a very special 3M tape that is very sensitive. So we try our best to prevent any type of abrasions for the baby, which is why we bring the babies in every 2 weeks to reevaluate them. As Dr. Byrd stated, the whole treatment can be between 4 and 8 weeks, and we do like to recheck it every 2 weeks just to clean it up, make sure the stabilizers are still in place. And here he is pulling away the backing. And if anyone wants any information, my phone number is on the side in the chat. Please text me and I will mail you the pin, the projectometer, and any brochures. He's just pulling that. All of this material is breathable and air can get through. It does not impact hearing at all. And if you can tell, the babies sleep sleep through it. Oh, Dr. Byrd, I think the video went back. But the babies sleep right through the procedure. We like to have the parents feed them right before, and they usually sleep through it. The older they get, the more aware they get. But towards the end of the treatment, they can often be awake.
Great. Thank you so much.
Yeah, we didn't get to see the end of it, but that's okay.
Yeah, you got the idea, I think,
Yeah.
from what we showed you.
Great.
And I'm going to stop sharing this, or if there are any questions, I'm happy to take them.
Okay, let me put up the questions again.
And I have the projectometer pins, as I stated, and I can see now people are texting me, asking me for those. But I have a big poster with all of the deformities on one page that you can keep with you, keep in your bag. You can put on the back of a treatment door.
Great. Let's see if we have some questions come up. And
forgive me if I missed this, Dr. Byrd. Did you let everyone know, I snuck away to go to the bathroom. Did you let everyone know that it is covered by all the major insurance companies? Okay.
Okay, so we have a few questions. One says, I have a question about where we can find a list of doctors who we can refer to for the ear well treatment. It says no providers are listed within the state where I live in Arkansas.
Yeah, the best way would be to go to Beacon, BECON Medical, and they keep a list of physicians who are doing ear well. So if in Arkansas, I know that we treated several babies in Arkansas and Dallas, but there may not be a provider in Arkansas. I don't know that for sure.
It will show you on. It'll show you on the map on Beacon if you put in your zip code. It's really nice.
Okay.
Oh, and I did want to just throw out there, Dr. Byrd. We know that some of you guys live in the outlier areas from our Dallas, Fort Worth Metroplex. You have my cell phone number. You can always text us a picture of the ear, and I will get it to Dr. Byrd, and he can make a preliminary evaluation on the baby before having to make you drive. He may tell you, text me the picture of the ear 1 week from now. He may say, absolutely, we need to get this baby in for treatment or consult now. But please plug in my cell phone number and feel free to text us a picture of the ear or have the parents text us a picture of the ear.
Okay, and for those of you who don't see the phone number in the Q&A right now, the phone number for Amy is 972-493-0839. One question is, has there been any notable impact to breastfeeding in those newborns molds in place?
No, the molds, they can be held any way that you would normally hold the baby. They can lay on the molds, so it doesn't require a specific position. The only thing that's changed is you can't immerse the baby for the head and the facial area. Needs to stay dry, so you can immerse the lower body bathing, but then use a damp washcloth for the face and scalp. And that keeps the moisture out of it, which can lead to problems, as I mentioned during the presentation.
Okay, one other question is, can we get a resource to compare normal ears to abnormal?
Yeah, there's a wall chart that we'll give you that has a list of all the common deformities that we've seen. Now, it doesn't have a normal against each one, but at the very top of the page is a detailed normal ear. So the wall chart is a wonderful asset, and Amy can mail that to anyone that wishes, along with the projectometer pins.
Okay, that seems like a great resource to have. There's another question that says, Dr. Byrd, do you see an increase of infants born with deformities and malformations of the ear?
Well, what surprised me was the number of malformations that I saw. When we first did our own personal study, where we were the investigators in the nurseries, the malformations were not as common as just deformities. But when I started doing a large volume of referral babies, I found that the malformations were what everyone was diagnosing. So in my clinical experience, all of a sudden, I saw a lot more malformations than I did deformities. But I think that was because they're so much more obvious on the baby, so they're more likely to be referred. So it's funny how that data split out a different way.
Okay, one other comment we have that says, thank you, very interesting. I always knew my ears were funny, but I realize now that I have a helical rim deformity.
Yeah, unfortunately, I may have ruined all of your lives because you're going to see this everywhere when you have dinner or lunch or whatever with other people.
Great. Well, thank you so much. Amy, could you put your phone number one more time in the Q&A? Someone says that I may have missed or transposed a few of the numbers as I was reading it out.
It's grayed out for me now, so here
Okay.
goes. 972-439-0839. And I have already received many texts, and thank you so much for the interest. And I will put all these packets together this weekend and get them in the mail to you.
Great. Thank you so much.
Thank you all.
Thank you, Dr. Byrd
Mhm.
and Amy. We appreciate you taking the time.
Everyone.